I'm very excited to be kicking off this next session on valvular disease, and you're in for a real treat with Dr. Nilay Patel, who will go over aortic stenosis, timing of intervention, and the choice between surgery and percutaneous therapy.
All right. Thank you. It's nice to see you all today. I look forward to spending some time talking about aortic stenosis. It's a big topic, and I'm hoping to provide not only sort of an overview of how we think about aortic stenosis as a part of our heart valve team, a big multidisciplinary team that takes the input of interventional cardiologists, surgeons, echocardiographers, radiologists, and really tries to make team-based decisions for the care of our patients. And so I'll try to sort of summarize how we think about patients in today's talk. I have no relevant financial disclosures. This is a brief outline of what I'm hoping to accomplish. Some segments I'll spend a little more time on than others. But just a word about the background, a little background in the pathophysiology of aortic stenosis, especially now in 2025, will be relevant to some of the topics that we talk about. Just as a reminder, aortic stenosis over time has become much more of a degenerative pathology, more than a rheumatic pathology as it used to be. If you look at patients above the age of 65, 25% have aortic sclerosis, which is known to be the pathologic precursor to aortic stenosis. 5 to 10% obviously go on to have more significant aortic stenosis. And once aortic stenosis becomes severe, the 5-year event-free survival is pretty abysmal. And so intervention is super important to think about the timing of intervention. When is the right time to intervene? Annually, we do a large number of aortic valve replacements in America, about 150,000 are performed. And balancing the right risks and benefits of intervention is incredibly important. The underlying pathology, though, across the board of aortic stenosis most commonly is calcific aortic stenosis, just plain old tricuspid aortic valves that calcify with age. But there are bicuspid and unicuspid phenotypes that we see, especially in younger patients with aortic stenosis. Rheumatic heart disease still exists, even though it's less common than it used to be. And then radiation-induced heart disease has become increasingly common as time has gone on. And with more focused attempts at more focal radiation exposure, we certainly have done a lot to curb this. The oncology teams in particular have done a lot to really curb this. It still is a very prevalent problem that we see. We often are asked about what are the kind of risk factors, like is there something I could have done differently to prevent having developed aortic stenosis? And it turns out there are a number of conventional cardiovascular risk factors that seem to contribute some additional or additive risk to AS progression. This particular chart, I think, hopefully emphasizes that most of those effects are pretty small. So in the kind of bottom corner here, we have Caucasian race, smoking, obesity, diabetes, hypertension. All of those have a slightly higher odds ratio compared to patients who don't have those pathologies. But the overall odds ratios are in the 1.2 to 1.4 range for the most part. So relatively small effect size. Far and away, the biggest of all of these risk factors is having an underlying bicuspid aortic valve. I normally breeze over this slide, but today I'm going to spend a minute on this. This is really a commentary about the underlying pathophysiology of aortic stenosis. Why does it develop? It's very, I think the most simplistic way to think about it is that it's a wear and tear problem, which it very much is. But the biological underpinnings of that wear and tear of an aortic valve over a long period of time is really well described scientifically now. And I think the pathways that lead to progression of aortic stenosis are well understood. And that largely starts with this initiation phase, that at the outset of aortic stenosis, there usually is an opportunity for LDL particles in particular to enter the subendothelium. Those LDL particles oxidize, they then lead to infiltration of inflammatory cells like macrophages and monocytes. As that happens, it triggers a cascade of osteogenic and fibrotic processes that include the TNF-alpha pathway, the IL-beta pathway, BMP2, Notch1 signaling. All of those pathways are incredibly important today in 2025 because now more than ever there's a renewed interest in finding medical therapy to prevent the progression of aortic stenosis, and we'll spend some more time talking about that. But that's really the kind of biologically active process that we see when we look at a PET scan of patients with aortic stenosis early in disease, where you see no aortic stenosis. It's a really no FDG avidity that's seen on the aortic valve. As you develop mild aortic stenosis, you can see the area where calcification is forming is the same area where we see biological activity. In moderate aortic stenosis, that process is ongoing, but by the time a valve has become severely stenotic, there's really no biological disease really active anymore. At this point, it's really burnt out disease. This is typically when we meet patients, but really the question is, are there opportunities to intervene in those earlier stages of aortic stenosis? So as we kind of march that out, as people develop aortic stenosis, we know that there is a progressive outflow tract obstruction, that blood can't exit the heart as effectively, and that results in a myriad of downstream ramifications hemodynamically for the heart. An increase in left ventricular systolic pressure, an increase in left ventricular end diastolic pressure, ultimately even a decrease in aortic pressure. All of those then lead to a mismatch of myocardial oxygen supply and demand, which leads to overt cardiac failure. That's really the symptom or syndrome that most commonly gets people to our doorstep to think about the idea of an intervention. But there's a lot of underpinnings of that really kind of start a lot sooner. And so we classically think about this chart that I'm sure many of you, everyone has probably seen. This is the kind of classic teaching of aortic stenosis, is that there's a very long latent period where aortic stenosis is progressing. And at some point, there is the onset of symptoms. And it's really at that point that the prognosis becomes quite dismal. And patients do very poorly over 2 to 5 years following the onset of symptoms. And so really important for us to try to catch patients at the time where we feel like they'll be most likely to benefit from our interventions. I do want to spend a little bit of time talking about the diagnostic criteria that we use for aortic stenosis, because this has evolved, I think, in our thinking about who are the potential candidates for intervention, what are the potential outcomes of intervention, really depends on what the subgroup of AS actually is. In 2020 and in 2021, there were ACC-AHA guidelines. The American College of Cardiology and the ESC, European Society of Cardiology, wrote their kind of joint consensus guidelines independently. They're very similar to one another. I will largely spend my time talking about the 2020 guidelines from the ACC-AHA, but certainly if there are opportunities to reflect on the differences of how our European colleagues practice, I'll try to share that as well. In general, there is a nomenclature about the stages of aortic stenosis that are shared within the ACC-AHA guidelines. And it starts with patients who are at risk. So I'm going to focus predominantly in this right-hand column, patients who do not have any symptoms. And if you don't have any symptoms, there is a stage A. These are patients who are at risk of AS. This is patients who might have a bicuspid valve or maybe have some aortic sclerosis. As they go on to develop mild or moderate aortic stenosis, they enter the progressive stage. So that's stage B. Stage C is severe asymptomatic aortic stenosis, and stage D is severe symptomatic aortic stenosis. In general, we think about stage D as being our kind of classic class 1 criteria for intervention, but there are some class 2A guidelines for patients with asymptomatic AS in the current guidelines. We'll talk about how that's evolved. And then there's an ongoing randomized clinical trial for patients with symptomatic moderate aortic stenosis. So all subgroups that we'll spend a little bit of time thinking about today. If you are following these patients longitudinally, fortunately, the kind of overall criteria, this is all I'll really say about the stage B type patients, is that we still follow them closely clinically, even if they don't have significant aortic stenosis. If they have mild AS, echocardiograms every 3 to 5 years. If they have moderate AS, typically every 1 to 2 years. If they have asymptomatic severe AS, echocardiograms every 6 to 12 months, in addition to clinical follow-ups. That basically mirrors aortic regurgitation, mitral stenosis, and mitral regurgitation guidelines. So it's basically the same time points for interval follow-up based on those criteria. So I'm going to spend a little time talking about the actual criteria, the categorization that we have for different subtypes of aortic stenosis. And I'm going to center it around a case. This is a case of an 80-year-old woman. She has hypertension and diet-controlled diabetes. She had come in with a complaint of 3 months of dyspnea on exertion, and also an episode of exertional syncope, and that's really what triggered her family to come in for an expedited follow-up. She had normal biventricular function on an echocardiogram and had a calcific aortic valve with the transvalvular mean gradient of 30, a peak velocity of 3.5 meters per second, a calculated aortic valve area of 0.8 square centimeters, and a stroke volume index of 27 milliliters per meter squared. She had no other significant valve disease. And so the question I'll pose is really, does she have severe aortic stenosis by echocardiographic grading? And to answer that question, there's really one kind of key framework I want to share with you all that I think many of us continue to use, and this is largely reflected in the 2020 ACHA guidelines, which is that you focus on three primary parameters. You look at the left ventricular ejection fraction, the transvalvular gradient, and the markers of flow. So EF and gradient, that's pretty straightforward. Flow, I'll take a second and say, is really just a question of whether or not the cardiac output is actually normal. And we assess that on routine echocardiography by assessing a stroke volume index. So let's march down each of these pathways. So if you have a normal ejection fraction, let's start there, and you have a high gradient, a mean gradient over 40, that defines severe high gradient aortic stenosis. That's a kind of classic group of patients that we think about for intervention for AS. But what if your EF is normal, but your mean gradient is less than 40? If your mean gradient is less than 40, by criteria, the next question is, what's the transvalvular flow? And if the stroke volume index, meaning the overall output of the heart, is adequately flowing, then that person would have a normal flow, low gradient AS. That's moderate aortic stenosis. That is not significant aortic stenosis, at least by the conventional criteria. However, if their stroke volume index is low in the context of a low gradient, you have a low flow, low gradient with a normal EF patient. That patient has paradoxical low flow, low gradient aortic stenosis. The paradox being that they have a low flow state despite having a normal ejection fraction. And we all know these patients, right? These are patients who have hypertrophic cardiomyopathy, normal or hyperdynamic EF, although they can have a low cardiac output. Amyloidosis, normal ejection fraction, but a low cardiac output. Those phenotypes of patients we have to have a really high index of suspicion for. And the patient that we're talking about, in this particular example is a patient who had a valve area of less than 1, a mean gradient of less than 30 with a normal EF. However, I told you her stroke volume index was 28, which is well less than 35, could be consistent with paradoxical low flow, low gradient AS. All right, let's shift to the right side of this. So now we have patients who have an EF of less than 50, so their heart obviously is not squeezing normally. Mean gradient is greater than 40. If you have an EF of 30 with a mean gradient of 50, that heart's in trouble. We worry about those patients a lot. That's a classic concerning group of patients with high gradient aortic stenosis. If the mean gradient is less than 40 and they have normal flow, meaning a well-compensated heart failure patient that's out in the community on good drug therapy with a normal cardiac output, that patient has moderate AS. That's not necessarily classical low flow, low gradient AS the way we think about it. It really is dependent on flow. So if mean gradient is less than 40 and our stroke volume index is less than 35, we think about those patients as having classical low flow, low gradient AS. And to really underscore that point, to help to improve their flow and to mimic what normal flow state would look like for them, we offer a dobutamine stress echocardiogram to augment their left ventricular output, to augment their cardiac output, to see if that will generate a higher transvalvular flow. So those are the subgroups. Those are the main subtypes that we think about. We have patients with moderate aortic stenosis based on these criteria, and patients who have severe symptomatic high gradient AS, classical low flow, low gradient AS, paradoxical low flow, low gradient AS. Which ones do we treat? Of all these groups that we've defined, which ones are the ones who are candidates for intervention? So if you have a symptomatic patient in front of you, the groups that we treat based on the ACHA guidelines are the patients who have high gradients and symptoms, regardless of what your ejection fraction is. And then if you have paradoxical low flow, low gradient AS or classical low flow, low gradient AS, by ACHA guidelines in 2025, we do not treat patients with moderate aortic stenosis, even if they have symptoms. We'll come back to that again, as I mentioned. In asymptomatic aortic stenosis, there's really only one group of patients that have a greater than class 3 indication for intervention, which is for patients who have a high gradient with a low ejection fraction. So if your gradient is high and you have a low EF, we're worried about a susceptible ventricle generating these high pressures to get these aortic valves to open. We intervene on those valves really with the hope of trying to improve the EF. That's a class 1 indication in the ACHA guidelines. And then there's a 2A indication for patients who have asymptomatic severe AS, basically to put them on a treadmill, see if they can augment their exercise capacity adequately, see if their blood pressure responds appropriately to exercise, and really understand if those patients are good candidates for intervention. If they can augment their their blood pressures appropriately, if they have a good workload, exercise capacity, and they have no symptoms with activity, we typically will continue to sit on them, at least on the basis of the contemporary ACHA guidelines. And that same thought process, that same framework is mirrored in the way that the flowchart in the ACHA guidelines are actually structured. This leftmost panel is our symptomatic high gradient AS patients. This next panel is the symptomatic classical low flow, low gradient AS patients. You have our paradoxical low flow, low gradient AS patients next, and then our asymptomatic high gradient AS, low EF patients, asymptomatic high gradient AS with some additional risk factors such as a low blood pressure or a hypotensive response to exercise. Those types of, these are really, the best data that we have for interventions largely in these patient populations. And so again, we try to stay fairly strictly to that criteria within our valve team to be sort of in line with the most contemporary data. But there's some updates that we have to talk about. For this particular patient, though, the one that we described, as we talked about, her mean gradient is low in the context of a normal ejection fraction and a low transvalvular flow. So by criteria, we could say that she has paradoxical low flow, low gradient aortic stenosis, and we could just go ahead and treat her. And she's a pretty symptomatic patient. She has a really concerning syndrome. We may well just do that. But in other cases, we might not be as compelled to do that. We might not be as impressed by the symptoms. We might not be as convinced that the aortic stenosis is severe. So ancillary data can be very helpful. So for anyone that's in the room that's taking care of this patient and wants to understand how do we find out if this patient really has severe AS, here's what we do. This is kind of how we think about it. We do an aortic valve calcium score in a lot of these cases. Aortic valve calcium scoring consistently can provide additional data to help you consider the probability of severe aortic stenosis. Just like a coronary calcium score, if your aortic valve calcium score in men is over 2,000 and if women it's over 1,200, it's likely consistent with severe aortic stenosis. These are not hard and fast rules or hard and fast numbers, but the best models that we have suggest that likely over 2,000 and over 1,200, and unlikely if men have an aortic valve calcium score under 1,600 and women have an aortic valve calcium score under 800. For patients with classical low flow, low gradient AS, dobutamine stress echocardiography is in the guidelines as an additional and very helpful next step. Low doses escalated up to 20 mics per kilo per minute to see if there's a concordant rise in the mean gradient to greater than 40 millimeters of mercury. And then the last thing you can consider is to do an invasive heart catheterization. I do this as an interventional cardiologist pretty frequently for patients with aortic stenosis where there's discordant data as an additional measure where we can quite literally place a pigtail across the aortic valve and measure simultaneous pressures in the left ventricle and also in the aorta. And at the same time, also assess what the intracardiac filling pressures are with the right heart catheterization, assess invasive cardiac output and indices, things like that, that can help to provide yet another sort of diagnostic criteria to consider whether or not intervention is appropriate. There are some other adjunctive tools that I'll spend a little less time sort of focusing on. They're interesting, they just aren't consistently or routinely used. Cardiac MRI is one of them. There's actually an opportunity to perform really high quality planimetry of the aortic valve. It can be a bit more challenging in calcified valves. And if the aortic valve area is low, if it's less than 1, it can be very helpful. But there's unfortunately not great concordance between aortic valve areas that are between 1 and 1.4, 1.3, and severe aortic stenosis by other criteria. So potentially a little bit more question mark, sort of utility in routine cases of AS. But we can do 4D flow nowadays. We can assess transvalvular gradients that way. It's, again, another perk of this particular modality, just not one that we routinely employ. And then TEE, if somebody doesn't have great transthoracic windows, TEE would be another appropriate option, recognizing that there sometimes can be an effect on transvalvular flow, gradients, blood pressure as a result of the anesthesia people need to do a TEE. So that may change the flow conditions across the aortic valve and may make it look less significant, even if it is quite severe. So how do we consider treatment? Treatment options for aortic stenosis. I'll start with the medical therapy story. Here for medical therapy, it turns out there's really no approved in the 2020 guidelines for aortic stenosis, any medical therapy that's deemed to be strictly speaking for AS. There is a class 1 recommendation that if you have hypertension, you treat hypertension. If you have a reason to be on a statin, take the statin. But aside from that, there's really nothing that is strictly speaking for the AS. We've tried to look for some, though. There have been about three that I've shown here and many other clinical trials that have looked at the effect of statins on LDL reduction. And although they potently reduce LDL cholesterol, we know that, they do not, in any of the clinical trials, show evidence of delaying the progression of aortic stenosis. Interestingly, though, there was an exploratory analysis done from one of the landmark PCSK9 inhibitor trials, the Fourier trial. This was a patient, stable coronary disease trial. 27,000 patients were enrolled and were randomized to medical therapy or evolocumab. And for patients that got evolocumab, after 1 year, there seemed to be a really significant reduction in the degree of aortic stenosis events. That was the primary endpoint of this particular analysis. And it raised this question, well, if it's not the LDL reduction, because the statin trials never showed that, is it perhaps related to lipoprotein A, which is an interesting question, but again, in an exploratory analysis, this was not designed or powered to answer that specific question. But interestingly, it has powered and accelerated a number of clinical trials. At Mass General, we're currently participating in 2 of them. There's a clinical trial right now looking at a soluble guanylate cyclase activator called atosiduat that showed in a very small phase 2 trial about a 70% reduction in calcification of aortic valve leaflet tissue after 6 months of therapy. So this is for patients with mild or moderate aortic stenosis with the hope of trying to delay the progression of aortic stenosis. For lipoprotein A, there's a drug called pelacarsen that's being studied in the Frontiers CAVS trial. Same concept, mild to moderate aortic stenosis in young patients with the hope of trying to delay the onset of severe aortic stenosis. So super interesting and frankly, a really nice change in the way that we've talked about aortic stenosis for years in the past, where we just immediately had to take these patients to intervention, kind of a renewed interest in medical therapy because of a better understanding of the biological underpinnings of AS progression. There's one last one that I'll mention, then I'll move on to the conversation about aortic valve intervention. So for this is the therapy of patients who actually undergo treatment for aortic stenosis. So specifically, patients who have undergone TAVR, who had heart failure symptoms as the indication for the TAVR. There was a nice trial called the DAPA-TAVI trial. This was a study looking at dapagliflozin 10 milligrams once a day. And the treatment, if they had underlying CKD or diabetes or systolic dysfunction. And there was a really nice early separation and sustained out to a year reduction in progression of heart failure symptoms in patients who started taking an SGLT2 inhibitor after their TAVR. So just as a recognition to the left ventricular remodeling that is happening in patients who have aortic stenosis, the pressure loading leads to some onset of heart failure symptoms that we may be able to more durably treat if we put those patients on an SGLT2 inhibitor. All of those things that I just mentioned are not in the guidelines, but a part of the contemporary thinking around aortic stenosis care. But really, I think, the kind of crux of what I want to spend the rest of our time talking about is how do we actually go about treating severe symptomatic aortic stenosis in 2025. And in 2025, we really have 2 kind of big buckets of therapies. The first is surgical aortic valve replacement, which has been around for about 50 to 60 years, and TAVR, which now has been around for 15 plus years. We're at the point now that I think we're about to cross maybe if it hasn't happened already, it just happened, the millionth TAVR that's ever been formed. So it's really a remarkably common therapy now in 2025. The story of TAVR, though, is really interesting, and I'm not going to spend too much time belaboring the clinical trials, but I do want to mention a couple of important observations that we can share with our patients when we talk to them about intervention for aortic stenosis. The first comes from the Partner 1B trial. This is the original clinical trial back in 2009 that looked at surgically inoperable patients who were so high risk that these patients were effectively just getting medical therapy. And in the very first clinical trial that was published on TAVR, there was a standard therapy arm, which was really the only placebo arm for AS patients that's out there. And watching those patients out to 1 year, 50% of them died. That's a really impressive number if you look at even the worst of metastatic cancers that are out there. Severe aortic stenosis in a medically comorbid population, this was a really important observation. And TAVR in this largely transapical TAVR era, which is sort of the oldest technology that was being done at the time, still meaningfully reduced the risk of death. This was all-cause mortality by about 20%. The high-risk trial then was performed. These were high-risk patients, so they did have a surgical option. So they got randomized to surgery versus TAVR, and out to 2 years, there was no difference in clinical endpoints. As the devices got smaller, as we largely switched from doing these procedures transapically to doing them transfemorally, the intermediate risk trial, these were patients who were less of the high-risk surgical patients but had some risk factors, got done. This was 2,000 patients. And surgery versus TAVR actually looked pretty comparable. Actually, TAVR looked a little bit better even at the PARTNER 2 trial. And really the groundbreaking trial was PARTNER 3, which was the trial that looked at the difference between surgery and TAVR in low-risk patients, patients who really conventionally for decades had only gotten open heart surgery. And there was a superiority of TAVR, meaning a significantly lower rate of death, stroke, or rehospitalization at 1 year compared to surgery. So it really kind of shifted a lot of the thinking, and the pendulum swung very much in favor of TAVR in this very short period of time, largely in response to the rapid publication, rapid engineering successes of TAVR over the last decade. So how do we decide now, right? I mean, like based on that, it would seem like we should just go for TAVR for most of our patients, and that obviously is not how we practice. And it still really does come down to some really important underlying questions. On the one hand, we think about what the patient's surgical risk is, what their underlying risk to undergo the surgery actually is. And really maybe chief among the considerations for whether or not to offer a given patient surgery is what's their age and life expectancy. Because one of the unanswered questions about TAVR, and I think it's incredibly important that we level set around this question is, what is the durability of a TAVR valve in 2025? And the unfortunate truth is we still don't really know, because the young, healthy patients that got treated in the PARTNER 3 trial were published and shared in the kind of late 2010s, right? Like this is 2017 to 19 largely. And so we're only now, later this month at the TCT, National TCT Conference, that PARTNER 3 trial that I showed you is publishing its 7-year data. And typically we think of biological valves lasting 10 to 15 years, so it's still just a little too soon to tell between the two, which is it that is going to last longer, have the durability that's necessary for our younger patients. If you have concomitant cardiac disease, like need for bypass surgery, coronary artery bypass surgery, if you have an aortopathy associated with a bicuspid valve, for example, maybe you'd be better served by undergoing surgery. Sometimes people will be low risk for surgery, but be high risk for TAVR. Just anatomically, there's some reason why a TAVR valve might not fit well in their aortic root. And other, shared decision-making models that really have proliferated, I would say, in the way that we have these conversations with patients today. Patients are so much more a part of the conversation about type of aortic valve replacement now than ever before. And it often is this kind of balance of understanding there may be some unknowns about the future and durability of a TAVR valve compared to surgery, which has been around for a lot longer, but is far more invasive up front and potentially has different risks. And then the last thing I'll say is just the need for a mechanical valve, which only can be performed with surgery, cannot be performed transcatheter. So if we're really thinking about a mechanical valve, it might be more appropriate to consider surgery for a given patient. How do the guidelines handle this issue? So in the guidelines, for patients who are under just to orient you, this chart looks at age on this gray arrow in the center. And then the ACHA guidelines are in this dark blue color. The ESC guidelines are in this dark red color. In general, for patients who are under the age of 65, the ACC guidelines suggest surgery. For patients above that are above the age of 80, the class 1 recommendation is for TAVR. And if you're between the ages of 65 and 80, there is a shared decision-making model, but both are considered class 1. The ESC guidelines are a bit more prescriptive. For low-risk patients under the age of 75, they say surgery. For patients above the age of 75, they say TAVR. So interesting, slight differences in the general thought process. We still, within our program, largely mimic that same concept. If you're under the age of 70, you're more likely to get surgery. If you're above the age of 75, you're more likely to get TAVR. 70 to 75 is kind of the gray zone. There's a couple of unique populations, though, that I want to make sure we call out. TAVR for bicuspid aortic stenosis. So bicuspid aortic valves were excluded from all the large randomized clinical trials. And subsequent data did suggest that there was higher risk for TAVR. Now, fortunately, in the most contemporary version of that data, that risk is fairly marginally elevated. I wouldn't say it's significantly elevated, but there are higher rates of stroke, pacemaker need and paravalvular leak that are clear and consistent. Now, fortunately, those are in the sort of 0.5% to 1% higher than baseline. But for a young, low-risk patient, that may be a really meaningful number in terms of the difference. For bicuspid aortic valves, because they are younger, they also really benefit from the durability of valves that we know will last 10 to 15 years. So again, another reason to consider surgery for them. But there are no randomized clinical trials of TAVR and bicuspid valves. That is important to just recognize that we'll likely never have one. It's very possible that'll never be performed. So no RCTs, meaning that there is a lot of extrapolation based on real world data that's all being done with some intrinsic selection biases and things like that. The last big topic I'm going to spend some time on is the patients who are asymptomatic. So for asymptomatic severe aortic stenosis, I had alluded to before that the ACC guidelines really talk about putting these patients on a treadmill. And the reason for that is to look to see if they have a normal exercise capacity, to look to see if they have a normal blood pressure response to exercise. When you or I or any of us exercise, our blood pressure should augment appropriately. And a hypotensive response to exercise confers a significant negative prognostic outcome for somebody who has severe AS. So putting them on a treadmill is very much in line with the way that we practice in our program. But there are some patients who are really just have very critical valves. Their mean gradient is 65 or 70. Peak velocity is well over 5. If they are otherwise at low risk or if their disease is progressing rapidly, we might just consider moving forward with intervention for those patients. In general, this idea of early intervention with the prospect of undergoing a surgical aortic valve, that's what the Class 2A recommendations all point towards, is based on the results of a couple of clinical trials. I'll name one of them was the recovery trial, which showed that if you had a peak velocity of over 4.5 meters per second or a mean gradient over 50, if you just watch these patients, even though they were asymptomatic, if you watch these patients, they were more likely to have death from any cause compared to if they just went for an early surgery. And so that idea of early intervention really originated from the data that was collected in the surgical literature from Recovery and Avatar. But that concept spurred a line of inquiry in TAVR that has really blossomed a lot over the last few years, all basically getting to this concept that when aortic valves get stenotic, even before they become severely stenotic, they are putting pressure on the left ventricle. And over time, there may be subclinical left ventricular cardiac damage that transmits backward to the left atrium, may lead to mitral regurgitation, which may even lead to issues on the right side of the heart with pulmonary or tricuspid cardiac damage, such as pulmonary hypertension, or tricuspid regurgitation, and even lead to overt right ventricular damage, so right ventricular systolic dysfunction and the worst of it. And it turns out that if you look at the association between those different outcomes, like meaning how sick is the heart going into the intervention, really predicts quite well what the outcomes are after intervention. So for patients who underwent a TAVR with severe aortic stenosis, based on which of those stages they were in, there was a substantially higher risk for all-cause mortality. And that continues to be true even if you're asymptomatic and waiting for intervention. And it kind of gets to this idea that perhaps if we can prevent the onset of subclinical cardiac damage, it may be beneficial for the heart to not get pressure overloaded over time. And so that really spurred the early TAVR trial. This was published at TCT last year. 900 patients with mean gradients over 40 and actually a normal exercise tolerance test were followed. And if you follow these patients longitudinally over years, there was a significant decrease in patients who had an unplanned hospitalization for cardiovascular causes. Now, that was the hospitalization that led to TAVR in a lot of these patients, and it happened in the first 6 months in a large proportion of these patients, about 50%. So it is basically to say that for patients who are asymptomatic, many of them cross over into becoming symptomatic kind of quickly, and potentially intervening on them sooner may help to stave off untoward events, in particular hospitalizations, and there was maybe a signal of even stroke, which is interesting but not quite biologically explained. that actually led the FDA to broadly approve TAVR for patients with asymptomatic severe aortic stenosis. This is not currently in the guidelines, but is still FDA approved, and I think leads to a lot of interesting conversations when we speak with patients about this particular issue, is like, what is the benefit of waiting in the wake of the early TAVR trial? And it extends even further now to other clinical trials that are happening, like the PROGRESS trial, where in PROGRESS, we're actually looking at patients who have moderate aortic stenosis, so have clearly not in the severe range, but have symptoms, and intervening on those patients with TAVR early compared to ongoing clinical surveillance. Now, this trial hasn't published yet. There's a lot of expectation that it'll be a positive trial, but we're sort of still eager to see how this particular trial is going to shake out when it gets published. And I think it really gets to this ultimate question of when is the right time to kind of jump forward with the idea of intervention. Again, unknown durability of a TAVR valve, known durability of a surgical valve, all of them are in the 10 to 15 year mark. We live currently in a part of the country that has among the highest life expectancy of anywhere in the country. And so for a lot of our patients, the earlier you start, the more likely you'll need repeat interventions. And if you start early, get more interventions, what's the right sequence of events? How do you safely offer that to our patients? This has become probably the principal focus of the conversations that we have in our heart valve team these days, of the younger patients in particular who are being considered for intervention. When you consider that, is it in the lifetime management of a patient who has aortic stenosis, is it TAVR first? Is it surgery first? What's the best way to implant the TAVR valve to be able to continue to access the coronaries, to be able to redo a TAVR if you start with a TAVR? These are the really kind of open questions that I think we're going to learn a lot more about over the coming couple years. I'll end with a few conclusions, which is to say AS is the most common acquired heart valve disease in the US. If you have uncorrected severe symptomatic AS, it's associated with a poor prognosis. Aortic valve replacement is remarkably effective. Medical therapy is actually evolving, finally, that we may have options for patients to delay the onset of severe AS. Low gradient AS is complicated. It requires a lot of hemodynamic, anatomic, and clinical risk factor integration. Choosing between surgery and TAVR is no longer just about surgical risk. We need more long-term follow-up data to help understand what the right procedure is for the right patient and when. And I hope that we'll get a more and more renewed look at this kind of asymptomatic AS and moderate symptomatic AS population as we hear more about these clinical trials and follow-up. So thank you so much for your attention. I look forward to talking more about it.
Thank you, as always. Hello. Oh, thank you, Dr. Patel, for just a tremendous talk. We'll go ahead and open up for questions. I see a question right up front.
I'm actually, I practice in Marin County, and probably the average age of the patients I see are probably in the 80s and 90s. So I was wondering if you might comment on, you talked about TAVR versus SAVR, but there's also just doing neither. So in terms of like frailty, how are you assessing those patients?
Yeah, it's a really important question. You know, there are always patients who we see where we worry that putting them through the intervention may be of high risk. It may be medically futile in a sense, that there really isn't a likely benefit to their intervention. For us, that largely comes down to are there life expectancy limiting conditions that would prevent us from or preclude us from considering intervention. Outside of that, we have very commonly taken care of patients, nonagenarians, centenarians who have been in consideration for TAVR. The published literature on the topic suggests that they still see a meaningful quality of life benefit. So we will have a very informed and in-depth risk-benefit conversation about need for intervention, expected outcomes for intervention, and recognizing that there is some upfront risk and perhaps more risk, especially for the more frail patients. But we try to do routine frailty assessments on all these patients, baseline 6-meter walk tests, baseline KCCQ questionnaires, so we have a good sense of where they are in terms of their baseline functioning, and then to help kind of guide what is the likelihood that intervention is going to help them.
Do we have questions online, Rory?
Sure. Yeah, thanks so much, Nalay. There was a question about the paradoxical low flow, low gradient, and the potential role of echo inaccurate measurements or not accessing the maximal gradient, and just maybe a comment on how you review the echoes and take that into account?
We benefit tremendously by having a great multidisciplinary heart valve team. So this actually does come up quite a bit, where we talk to a patient who has very classic symptoms of aortic stenosis, but an echo that doesn't clearly tell the story. So again, we do routinely get and obtain more data points. Typically that would include a cardiac CT scan and potentially an invasive heart catheterization, much less commonly a TEE or cardiac MRI. In our practice, our structural echocardiographers, there's a group of echocardiographers who join our heart valve team calls and are really integral part of our heart valve care. We'll review the echo live during that conversation when we're reviewing a given patient's case to talk about what maybe some of the technical limitations are of a given echo, or reasons why the echo was probably right in the way that they estimated the degree of aortic stenosis. So often very productive conversations to have in that multidisciplinary heart valve team format.
Great, thank you. And a sort of related question in terms of evaluating the coronary arteries prior to TAVR, if someone's had a history of stents, do you cath them, or do you do the coronary CT? How do you approach that?
Yeah, it's a great question. Concomitant coronary disease is extremely common. Actually, next to bicuspid aortic valves, it's the most common enriched cardiac risk factor for patients who have aortic stenosis, so super common. For coronary disease, in our practice, we do routine cardiac CTs that assess the coronaries as well. 50% of our patients, we are able to obviate the need for cath by clearing their coronaries on the basis of their gated cardiac CT that they needed for TAVR planning in the first place. In the remaining 50%, there may be moderate or severe coronary disease detected on the CAT scan, and then really we try to individualize it to a given patient. In some cases, there is more and more data coming out that suggests that less coronary intervention may be appropriate for patients who undergo TAVR, because coronary disease can be managed medically. We've learned that from so many large clinical trials now. The largest clinical trial in TAVR to date is called the Complete TAVR trial. It's an ongoing enrollment at many sites across the world that are randomizing patients who have undergone a successful TAVR to medical therapy for their coronary disease versus PCI. And the idea and the hope is that we'll learn more about what the outcomes are for coronary disease patients who are unrevascularized following TAVR, and to see if that's an appropriate or safe strategy. Currently, a lot of retrospective data suggests that that's a very appropriate choice for many patients.
Thank you. And you also talked about the biology of aortic stenosis. Is there any data or awareness if patients are taking calcium supplements for osteoporosis? Does that impact AS progression, calcification?
Fortunately not. Usually it requires some dysregulation of calcium metabolism. So chronic kidney disease, osteoporosis, Paget's disease, those types of diseases, hyperparathyroidism, usually it's some type of dysregulated calcium metabolism that more specifically will lead to progression of aortic stenosis.
Can you talk about the current state of antiplatelet management after TAVR?
In general, in 2025, we are more minimalist than ever before. And so baby aspirin post-TAVR is the routine recommendation. There have been even studies that have looked at post-TAVR no antiplatelet therapy for patients who are at very high risk for bleeding. So there is a move towards doing less and less, especially for a high flow bovine pericardial valve, potentially a reasonable option to be less intensive, especially because so many of our patients are older, frail, at risk for falling. So the de-escalation of therapy is definitely more common. That said, a part of the story of durability for TAVR valves is really the risk for TAVR valves to form either subclinical or overt valvular thrombus. And there may be in the future more individualized strategies for thinking about what is an appropriate antiplatelet strategy based on your baseline bleeding risk, as opposed to like an all-comer just gets a baby aspirin type of strategy. Perhaps the younger patients who we're trying to optimize for durability, we may put them on anticoagulant therapy, for example, for 3 months after their TAVR. That's not the contemporary thinking, but maybe a future way of thinking about this issue.
Thank you.
Great. Thank you so much.
Thanks, everyone.